I'm Matt Spinelli, Associate Professor in Division of HIV, ID, and Global Medicine. And it's my honor and pleasure to introduce our speakers today. We have Dr. Jorge Salazar, a new, maybe we have to stop saying new now, but assistant professor in our division, and doing a lot of great work in the ID clinic on the clinical service. And next we have Dr. Vivek Jain, Associate Division Chief, Director of the ID Clinic, the clinical service now. So very excited to hear about some of the cutting edge science that was presented at ID Week this year. So.
Good morning. Thank you for being here and making it through the rain. Pleasure to be here. Thanks for the invite. All right, let me just dive in. So Dr. Salazar and I are going to do a two-part talk. We'll take half an hour each. And our goal is to give you kind of a high-yield summary of interesting things that came forth at the IDWeek2025 conference. So this is my only disclosure, not related to this presentation. And just start with a quick overview from my perspective of this conference. It's a really great conference. It's a little bit more clinical. It has 5 major tracks in it, spanning the whole field of ID. They have a lot of concurrent programming, and there's just a lot of fantastic stuff, but a lot of content. So it's pretty impossible to get to everything, but they have a really nice video platform. So part of going to this conference is then watching a few things on video later that you missed. Goes without saying for any report back, but there's too many interesting and great things for us to fit into this hour. We're going to do our best to zip through a lot of abstracts, the ones that we think are the most interesting, but also things that can actually impact our clinical practice starting today. And just from the organizing perspective, I'm part of the planning committee for the conference, and it was an interesting year. The conference was in Atlanta, and so one of the goals had been to really highlight and spotlight colleagues at the CDC, NIH, state public health workforce, but this proved pretty challenging. There were travel bans, budget stoppages, and attendance was a bit lower at this conference this year because we were missing a lot of CDC and NIH colleagues, as well as colleagues from a lot of universities who had travel restrictions put on, but nevertheless, very large and successful conference. I would say the vibe was great, as it was at CROI. Determination, a lot of shared community, and a lot of discussing about how we can advance ID care in pretty unprecedented times right now. Okay, so I'm gonna dive in. Just have my clock on the table here. These are the 5 things I'm going to try to hit for us. I want to talk to you about a couple of very interesting studies in the world of the zoster vaccine. Then a couple of interesting things from the world of RSV vaccine, COVID prevention with the pemivibart monoclonal antibody. And then I want to present a couple of things on bacterial diseases related to Staph aureus, and one study on C. diff colitis. Okay, so let's just dive in. So the first abstract I'm going to highlight is zoster complications that can happen after you get zoster, and part B, the benefits of zoster vaccine. So this is the abstract 218. As background, these are items everyone here already knows, but I want to just frame this for us, that zoster has major morbidity associated with any zoster infection. There are over 1 million cases of that annually in the United States. And it's widely recognized as not only having acute morbidity and mortality, but also a variety of long-term inflammatory and vascular and neurologic sequelae. We all have a lot of patients who've had shingles, and some of them make it through, and some are really left with a lot of lingering things. The recombinant zoster vaccine, Shingrix, is highly effective in preventing cases of zoster, but 2 questions frame this abstract. One is more data are needed on the consequences after zoster infection. We know it's bad, but we could use more data on what is happening. And more modern question, what is the clinical trajectory if you get zoster after you've had the zoster vaccine, i.e., is it milder? So this group worked with an aggregate of electronic medical records, kind of a cohort of cohorts called TriNet that comprises 107 health systems. And they did a retrospective cohort analysis, and it had two parts. One part to address each of these two questions here in red. So the first was adults 50 and over who had not had zoster vaccine, who then had uncomplicated zoster or some other kind of acute nasopharyngitis as controls. The second analysis was people over 50 who had either had zoster or pneumococcal vaccine and then got acute zoster. So they excluded complicated or disseminated zoster and a variety of other major comorbidities. And they did propensity score matching to try to control for confounders. So in the first analysis, this was very large actually from the EHRs. So this is people who had either had acute uncomplicated zoster or a common cold, 87,000 plus patients per arm. And this is to look at the first question is, what do the outcomes look like if you get zoster and you're unvaccinated? In the second analysis, it's people who've had zoster vaccine versus have not had it, and look at the outcomes after zoster to see if they're milder. And here are the results. So among people who had not been vaccinated against zoster, outcomes were much worse after a zoster infection than after a common cold. So this is consistent with what we know, but it added a lot of granular data because they did a really nice outcome adjudication for a variety of sequelae. So over here on the right, you can see that major cardiovascular events were increased 1.2-fold, MI 1.27-fold, stroke, VTE. All of these cardiovascular outcomes were substantially increased after zoster. And interestingly, dementia, either all-cause or specifically vascular dementia, was also increased in the window of follow-up, which went out to 5 years. This is a really interesting story that's been developing in the world of zoster, increased recognition that one of the long-term sequelae after getting shingles is an increased risk of dementia. There have been a couple of major studies published on that this year. There was also an increase overall all-cause mortality, 1.29-fold higher. So the message from this is this is not surprising, but it's just great to have these granular data. There's very substantial morbidity and mortality after zoster infection when you have not been vaccinated. And the risk, if you break this out into all the different types of sequelae after zoster, all of them, the risk accrued over time, kind of evenly. The curves separate and the gap gets wider as the years go on. So this speaks to this kind of long-term inflammatory sequelae long after the zoster itself the acute infection is resolved. Okay, now and then part two, which is I think a little bit more novel and interesting, is when people got zoster vaccine and then get zoster, it was less dangerous than if they had not had the vaccine, okay? So having had the vaccine attenuates the severity of the zoster. And over here are the same major outcomes: MACE, stroke, all-cause mortality. These went down substantially among people who had had the zoster vaccine. So not only does zoster vaccine prevent zoster, we know that, these are nice data showing that over a long period of time, several years, they actually prevent several of the sequelae as well. I just want to highlight that the dementia finding was non-significant here, and that was one of the things they highlighted. Okay, so adverse sequelae are lower in people who have received the zoster vaccine. And these benefits, the curves here are flipped, blue and orange, because these are now benefits accruing over time. Okay, so yes, it could be the older one or the newer Shingrix. So the final message from this study is really we need to encourage all eligible patients to get the zoster vaccine. It reduces chance of infection, and if you get infection when you have not had vaccination, that carries a lot of adverse outcomes. If you do get an infection, having had the vaccine reduces your chance of serious complications. Okay, this abstract 402 It was from the same group, exact same methods, cohort of cohorts from electronic medical records, but specifically looked at HIV positive individuals and similar, very positive results. And I'm not showing them here in the interest of time. You can look up this abstract, but the sequelae of getting acute zoster were more substantial in HIV positive individuals, and the attenuation of the effect of a zoster case was more beneficial among people with HIV. So just want to return to this message here in the lower box. This message is especially true for our patient population. Okay, switching over to RSV vaccine, effectiveness and durability of antibody titers. So to frame this topic, I think we all know this. In the summer of 2023, RSV vaccine was recommended one dose for persons age 60. And then this got updated in the summer of 24 to broaden the eligibility. Even though this vaccine has great efficacy, the current healthcare utilization data show that only 48% of persons 75 and over have gotten it, and only 38% of persons aged 60 to 74 have gotten it. So that is under what we had hoped for this vaccine, which actually has really great data. People know there are 3 RSV vaccine products: Arexvy by GSK, Abrysvo by Pfizer, and Moderna has an mRNA vaccine. That's the third one. 2/3 of people have received Arexvy, 1/3 of people have received Abrysvo, and a very small number have received the RNA so far. But interestingly and troublingly, evidence is mounting that the efficacy of this RSV vaccine, which was billed initially as a quote one and done single shot form factor, the efficacy is waning with time. So for example, the Arexvy, there's data showing that it had an 83% vaccine efficacy in season 1 that declined to 56% in season 2. Similarly, Abrysvo data show 89% VE declining to 78% in season 2. So with those kind of things brewing on the horizon, this study tried to do 2 things. First, they wanted to assess the vaccine effectiveness in adults 60 and over overall, and in subgroups of age, and in subgroups of immunocompromised status. So an important question in this field: is the vaccine efficacy worse in immunocompromised people? Is the antibody titer going to wane more in immunocompromised people? That is unknown. And second, they wanted to look at vaccine effectiveness, not just against getting a case of RSV, but against hospitalizations. And they wanted to know, does it vary by the brand of RSV vaccine? Is there anything we can learn about Arexvy versus Abrysvo? So the investigators worked within a different cohort of cohorts called Vision Network, spanning 230 hospitals in 7 states. And they used this kind of classical test negative design from late 23 through 2 winters into the spring of 25, looking for adults 60 and over who had been hospitalized for an RSV-like illness, which they call RLI. That is an analog of the more well-known ILI, influenza-like illness. And they look to see if an RSV test is either positive or negative. Over here on the left, the blue bars in this graph show cases accruing predictably as expected through 2 different winters. And the gray bars show you the test negative hospitalizations also accruing in the same time frame. So it shows you that the controls they selected are happening at the same time. People who got hospitalized for RSV versus for other things showed really no differences in age, sex, race, and ethnicity. But RSV vaccination and completion of that was more common among older individuals and among the non-Hispanic white population, as well as higher quartiles of the social vulnerability index score, which is an overall metric of income and connectedness to healthcare. So unfortunately, we're seeing the classical patterns of disparities already showing, even though we've only had this vaccine for a couple of years. Okay, so here are the data. Interesting. So if you focus in the red box first, RSV vaccine reduced the chance that your hospitalization was for RSV compared to for some other illness. Okay, so if you have the unvaccinated group and the vaccinated group, it tilts more to the vaccinated among the RSV negative group. as you would expect. And in purple, this is Arexvy versus Abrysvo versus the Moderna mRNA vaccine. These did not appear to result in any different effectiveness estimates using this test negative design method. So next result was they looked at, remember I said not just efficacy against cases, but what's the efficacy against hospitalization? And that was shown to be 61%, and efficacy against critical illness 69%. And here's the most interesting part of this presentation is that the vaccine efficacy really clearly appears to decline with longer time since vaccination. So in this first blue box over here, you can see increasing a number of days since vaccination, and the vaccine efficacy just steps down and down and down as you get further and further away from the vaccination. And actually, the fifth box, 366 to 591 days, is really only like a year or two since your vaccination. And we've already declined in this estimate from 84% VE to 41. So we have, really, I would say, mounting solid data that efficacy is declining. That waning efficacy was seen in people aged 60 to 74. It's the red box. You can see these numbers going downward. And in the people 75 and over, the waning was more, and it waned to a lower efficacy. So that's also expected as older individuals have less uptake and less durability of their vaccine immunity to any vaccine. Okay, so, and then in immunocompetent versus immunocompromised persons, it looked similar. They both waned in their efficacy, but not differentially. This is actually different from this major paper that came out in JAMA in August, which really raised the flag that vaccine efficacy was going to be lower among immunocompromised individuals. That was not found in this study. And then lastly, no difference between Arexvy and Abrysvo over these two seasons. So here are the final messages. RSV vaccine is effective, highly effective. We need to encourage its use for everyone that's eligible. But I think it's clear that vaccine efficacy is waning over time. So I'm thinking of this less as a one and done thing. That's what it's licensed for right now. But I'll just say, I think it's clear urgent studies are needed of booster strategies now. Okay, yes. Yes, I have not presented neutralizing antibody titer data, but there are, and they decline. Yes. Okay, third topic, COVID-19 prevention with the monoclonal antibody pemivibart. So this is abstract 660. So just to frame this topic, just doing a quick time check here, good. To frame this topic, I think everyone knows there is only one monoclonal antibody remaining that is still licensed for use in preventing COVID-19. So giving it to people before they have COVID to block and prevent COVID. That is pemivibart. It's given every 3 months. This was licensed in early 2024, and it's specifically for people with medical conditions, advanced comorbidities on immunosuppressive meds, or people who are unlikely to mount a vaccine response. The flagship data for this product comes from the Canopy RCT, which was published earlier this year, and that showed substantial reductions in the adverse outcomes that they were looking at. Okay, so COVID and COVID complications. Interestingly, unlike prior monoclonal antibodies whose effectiveness kind of came and went as the virus continued to evolve, pemivibart has appeared to retain activity for the year and a half that it's been in our hands, including now in the fall of 2025, and including against the XFG variant of COVID, which is currently, even of this week, the dominant one that is circulating. And because of that, it has remained licensed by the FDA for ongoing use. Okay, so really interesting product, and a preventive therapy is a great thing. Despite this being such an interesting antibody, there's hardly any literature on it. There's almost nothing in PubMed about it, and so we are really wanting data from practice groups. And that's what this study delivers a little bit of. So this group did a multi-center retrospective review assessing real-world pemivibart performance. They aggregated data across a bunch of private practices and infusion centers in 8 states. One of those 8 is California, and the ID practices in Walnut Creek. So it's just interesting. You get to see lots of cool stuff like this at ID Week, where sometimes these are university aggregations, sometimes they're electronic health record aggregations. This is a third mode that you see sometimes, which is private practice and infusion center aggregation. So they went from May 2024 to August 2025 and looked for people fitting the criteria for pemivibart. That's people aged 12 and over with moderate to severe immunocompromising conditions and or unlikely to mount a vaccine response. I've listed them here as to what those were. To be in this analysis, you had to have had at least 1 dose of the antibody. And then they looked for incident COVID-19 healthcare use and adherence to scheduled doses of pemivibart. And this analysis is small but valuable because there's hardly anything like this out there. So this is 48 patients. People got a median of 4 doses, so they stuck with it for a year or more. The median age of people was 68, 2/3 female, 73% had prior COVID vaccination. And the data are these, which is that there were 0 incident cases of COVID in everyone in this analysis. Nobody got COVID. 1 person out of 48 had an ER visit for a pemivibart side effect. And because anaphylaxis was a side effect that came up in the Canopy RCT, they specifically looked for that. And there was 1 person out of 48, which is not minor, who had anaphylaxis. So my take homes from this study are it's a little aliquot of data, once again showing pemivibart is safe and effective for COVID prevention. But it's nice because it's from a small real world study, real practices using an infusion center, treating people. So, I would like to encourage the use of this for patients who are the right fit. That being said, there are real logistic difficulties and barriers and a high cost to this drug. So these are real impediments to us, doing everything we can with pemivibart, but we are trying. But the good news is it retains activity even now in the fall, so it's still on the menu. Okay, let me continue at high speed here to, as you all know, one of my favorite topics, dalbavancin. This is a small study of treating folks who have Staph aureus endocarditis, persons who inject drugs. So to frame this, people know this, dalba is a long-acting lipoglycopeptide antibiotic that is very effective against gram-positive organisms, and it's approved for one thing, skin and soft tissue infections. Can give it as a single dose or 2 doses 7 days apart. But as you know, therapeutic strategies harnessing dalbavancin for lots of other infection syndromes and lots of other types of infection are expanding. Just recently this year, a really fundamental RCT called the DOTS trial was published of dalbavancin ×2 for endocarditis, and that found that it was not superior to the standard of treatment by this interesting endpoint method called the DOR, but it did appear clinically non-inferior to standard therapy. And so the data in the field of ID have been broadly taken as quite encouraging. So, and we are thinking about dalbavancin more and more, I would say, with each month that goes by for complex situations like endocarditis. So this study, Abstract 451, looked at the comparative effectiveness of dalbavancin versus standard treatment for Staph aureus endocarditis among PWID. Okay. And one thing is, so this was adults age 18 to 80 with this Staph aureus, could be MSSA or MRSA. They had to have gotten dalbavancin or standard of care. They had to have had substance use history. And they importantly included people with left-sided endocarditis, which had been excluded in the DOTS trial. That only had people with right-sided endocarditis. So degree of difficulty went up a notch with this group. And this was done in a cohort of cohorts called TriNet X. That's 144 healthcare facilities stitched together with their EMRs. And here are the results. So upper left graph, the substance use histories were not a, I wish there had been more data on this, but there were a lot of folks with opioid dependence, quite prevalent use of nicotine. 16 and 13% had an alcohol use disorder. Importantly, no comment was made on stimulant use. Patients had a variety of comorbidities, including CKD, hypertension, depression, obesity. These seem to be reasonably well matched. In the lower left is the main result. So the mortality in the dalbavancin group was just about 7%, but was quite a bit higher in the standard of care group, about 16%. So there was a 56% reduction in mortality over the 1 year of observation with the dalba group compared to the standard of care group. And we've pointed this out in other times. We've talked about dalbavancin, but the curves continue separating long after dalbavancin is well out of the system and the endocarditis would be expected to be treated. And we keep seeing this with dalbavancin studies. So this, I think, speaks to two things. One is the long-term deleterious impact of having endocarditis and having it be suboptimally treated. But it might also represent, getting better connected to care, getting in substance use disorder care. Many other things can happen when we start with dalbavancin. I'm not sure. I have to go back and look for that. I think, well, dalbavancin was completed at the standard therapy group. If it's most cases like this have incompletion of therapy, and it's part of why it's inferior. Safety was good with dalbavancin. And if you look at the blue bars, there was substantially less kidney injury, less incidence of rash, and the C. diff rate was a little bit lower with the dalbavancin. So these are all things we would have expected and see. So my messages from this study are pretty simple. This is a nice, small retrospective cohort study. Dalbavancin was effective and safe for people who are injecting drugs who have Staph aureus endocarditis. Benefits accrued continuously over the whole year, which is interesting. And I would say these data support our ongoing expansion of how we think about dalba, especially for difficult things like endocarditis, including left-sided endocarditis, probably the biggest new thing here. Okay, I've got a couple minutes left, really quick one. This was a really interesting abstract on using phage therapy for difficult Staph aureus infections in the form of diabetic foot osteomyelitis. So I think people have some familiarity with phage therapy. Well, first, diabetic foot osteo, we have all cared for patients with this tough condition. It's highly morbid, often needs surgery. Wound healing can be a problem. And it unfortunately has a very high recurrence rate, even with a successful initial therapy. So this is a challenging entity. Phages are a type of virus that infect specific bacteria. They replicate inside the bacteria, kill the bacteria, and then they amplify themselves. A certain number go in and orders of magnitude higher number of phages come out. So they're self-sustaining, but they're amazing because they're safe and they only affect the target bacteria. So it's a novel therapeutic class for a whole variety of hard to treat bacterial diseases. This study here, abstract 234, was a phase 2 randomized double-blind trial by this company called BioMX of a Staph aureus specific phage called BX211 that they got from a phage bank and matched to the patient's staph isolate versus placebo. And it was either phage or placebo layered on top of standard of care. So that is antibiotics, doing expert podiatry care, seeing the patient frequently. And the outcome, the primary outcome they looked at was reduction in the foot ulcer area by the end of the 12 to 13 week treatment. And this was done in 41 patients. So the first treatment is IV, but then interestingly, and that's how I know phage therapy mostly is these IV infusions, but interestingly here, all the rest of the weekly treatments in these first 12 was topical application of a solution containing phage. That's easier than an IV. It's interesting, and I haven't really seen a lot of that. This group had a mean age in the 60s. mean BMI around 30, about a third were smoking, about half had MRSA versus MSSA, and the diabetes that they had was moderately and not that well controlled. Here's the main result. So as you go through the first 12 weeks, the ulcer gets smaller in both groups, but then in the orange line, you can see the ulcer then sort of stops improving and then worsens in the placebo group, whereas in the blue dots, the ulcer keeps getting smaller. They did this nice graphic where a red line means the ulcer is going all the way to bone, and then different levels coming better and better up to the surface. And you can just see visually all the red bars turn into a variety of green bars by week 13. So the ulcers are getting more shallow and getting more healed by week 13. So interesting results. So my takeaways from this were we saw some improvements in the ulcer area when the phage was used on top of standard antibiotic therapy. So this is not a replacement for antibiotics, but an adjunct. And this is safe. It looks like it improves outcomes. The con would be a pretty onerous regimen. It's hard to do this. You need a center that really can set up for this. And you also need to get and obtain the phage and have it customized for the patient. But I will say we should all be looking for phage options to expand because there are a lot of interest in this field and a lot of phage libraries are getting easier to access. So there are processes for ID groups around the country to send your patient's bacteria to the library, get a match, and then receive a phage back. This whole thing is expanding. Okay, I'm gonna actually skip this last study just to tell you that it's in the slides and these will be available. This was a small RCT for C. diff colitis. And the question in this field is, when you have a recurrent episode, so the second, the third, or more episode of C. diff, what is the best treatment strategy? Most people favor fidaxomicin, but this was a trial looking at old style Vanco for 10 days, new style fidaxomicin for 10 days. That's what we favor. Or going backwards a little bit, try to resurrect old style Vanco, but add on a taper, a nice long 3-week taper. So this question's kind of interesting. You might wonder, why is anyone even studying this if we have this newer, better drug, fidaxomicin? Just because the data is not super clear that it is way better than Vanco. It is more expensive, and Vanco is well tolerated. So the basic result, I'll just skip to. The fidaxomicin in this study did not appear better than old style Vanco, whereas their tapering strategy did appear better than Vanco. So it's kind of an interesting little counterintuitive result. I still favor fidaxomicin as your standard approach for recurrent C. diff, but I like this abstract because if you're in a situation where it's not available, it's too expensive, you can't get authorization, I think this helps tilt us towards Vanco with long taper rather than just standard Vanco. I included here just some other recommended sessions that happened at the conference. I just wanted to spotlight wonderful talks that were given by Karina Marquez, Matt Hickey, and Ted Rull, all from our group here at UCSF. Amazing overviews of great topics. Had a couple of debates from the HIV clinic that you can check out. And that's it. Just want to thank everybody. And these are the puppies. You know about this from last year. They bring puppies into the conference. You can just go sit with them. It's basically one of the greatest things at a conference. So with that, I'll turn it over to Dr. Salazar.
All right. Thank you so much for that incredible overview, Dr. Jain. So I'm going to go ahead and move right on. I have lots of updates from the HIV side. Lots of studies on lenacapavir, related studies on drug-drug interactions, TAB and ZAB, some studies from the real-world settings, which I might skip. There's opportunity to go over that later on today at our ID consult meeting. And then some selected topics from 2-drug ARV regimens and one really unique study from capitalpivirine. I'll go through that. So to put some background regarding lenacapavir and this drug-drug interaction studies from Purpose 1 and Purpose 2, we know lenacapavir is a first-in-class novel capsid inhibitor, but it's also a moderate CYP3A inhibitor, and therefore has potential to increase substrates that are metabolized by this pathway.
some of these substrates of interest are hormone therapies, so estradiol, testosterone, progesterone. Fortunately, in the Purpose 1 and Purpose 2 studies, there were several participants who were on hormone therapy for contraceptives or gender-affirming hormone therapy. So Purpose 1, we are very familiar with this study in cisgender women randomized to receive lenacapavir versus FTAF or FTDF. In this study, participants were given free contraception. They looked at 3 contraceptive formulations: medroxyprogesterone, acetate, norethindrone, enanthate, and tanogestrel. So these are long-acting progestin-based contraceptives. They measured hormone therapies at baseline before they received len, and then through week 26 after they received len. And they used a population PK model to assess the impact of len co-administration on hormonal contraceptives. The inverse, whether hormone contraceptives affected len, was previously studied and didn't show any interactions. So this was a large group receiving lenacapavir, over 2,000 patients, but of those, just over 200 were receiving both len and hormonal contraceptives through at least week 26. And I'm just showing the main results in large graphs. So this is medroxyprogesterone acetate concentrations. This is what we know as Depo-Provera, so it's an intramuscular injection. So we see here on the y-axis, day 1 through week 52, these concentrations are remaining basically the same all throughout the study period. Same thing with norethindrone and enanthate. This is actually not available in the US. The brand name is Noristerat. Again, from day 1 to week 52, baseline concentrations are about the same. And then lastly, this is the implant that we know is brand name Nexplanon or Implanon. From day 1 to week 52, also these concentrations are remaining pretty stable, except for day 1 to week 13, there was a slight increase in the concentration. There was no explanation of what this was about. But because of this increase in concentration among these participants, the investigators specifically focused on these participants, queried whether they had any adverse events that might be related to this hormone, such as abnormal uterine bleeding, heavy menses, intermenstrual bleeding, but they did not see anything. It was all similar across all these groups that were receiving or not receiving this hormone. So the bottom line takeaway was that len co-administration did not result in any significant changes of these long-acting hormonal contraceptives. However, these were only progesterone-based. They did not study combined oral contraceptive methods, which are probably more frequent in use in the US. But fortunately, in Purpose 2, we do have some data on estradiol. So Purpose 2, we know, was in cisgender men, gender non-diverse or gender diverse people. And in this study, participants were using feminizing hormones and masculizing hormones. They queried their use among all the participants throughout the study. Again, they measured baseline hormone levels before receiving len through week 52. They specifically measured serum estradiol, plasma testosterone, and then plasma dihydrotestosterone. Population PK analysis performed to assess impact of len co-administration on gender-affirming hormone therapy concentrations. And again, large initial sample, just about 12% of individuals were on gender-affirming hormone. Most of these were transgender women. And then again, just showing the graphical results. This is serum estradiol from day 1 to week 52, remaining stable. Testosterone and DHT also remaining stable from day 1 to week 52. So again, len co-administration with gender-affirming hormone therapy had no significant changes in PK. My take-home message was I thought this was pretty exciting emerging data, providing some basis for clinicians to discuss with patients that it's quite safe to use lenacapavir. Some of these patients might be having barriers or hesitancies to use lenacapavir with concern for their hormone therapy. So this is some of the first emerging data that shows that it's safe, but this is only about 1 year worth of data and follow-up. So next is from Purpose 2, also a sub-analysis among this larger study. Here they wanted to examine len adherence, safety, and then the potential drug interaction between lenacapavir and fentanyl, specifically among patients with substance use. And so in Purpose 2, there was quite a large people that self-reported binge drinking. You can see in this graph here, over 40% of patients. This was defined as over 6 drinks at one occasion over a month period. Then also a significant amount, about 37% that self-reported any drug use. And as you can imagine, this was a range of substances: methamphetamine, cocaine, stimulants, sedatives. They did exclude cannabis use here. And then small numbers with opioid use and small numbers of injection drug use, about 33 patients and 17 patients respectively. But they were wondering about adherence in this patient population, which might have other social structural barriers. Generally, for LEN adherence and on-time injections, it was similar. You can see at week 26 results, week 52, adherence and on-time injections in the substance use group was pretty high, 89 to 96 in week 26, then upwards to 100% at week 52. And then with regards to safety, it was basically similar across all groups. As you could imagine, injection site reactions to lenacapavir were pretty common, 83 to 91%. No serious adverse events related to lenacapavir. And then there were 6 deaths, but none were related to overdoses. And then they just had a small mention about evaluating fentanyl and lenacapavir drug-drug interaction. They didn't show robust results, but they just mentioned there was a preliminary PK model showing no significant interaction between lenacapavir and fentanyl. So the bottom line was adherence to LEN was high. Again, I showed up upwards to in the high 90s to 100% on-time injections in this group. Safety profile was similar with the exception of injection site reactions to lenacapavir. And then there was no clinical significant interactions between LEN and fentanyl. So I think lenacapavir should be continued to be offered as a sexual health package to this group, offered as a highly safe prevention tool. But there will be more data from Purpose 4, which is enrolling in the US. And this is specifically to evaluate LEN versus TDF, specifically in people who are injecting drugs. So there will be more data on this in this patient population from the Purpose 4 trial. So next, I'm going to segue to LEN in combination with monoclonal antibodies teripalimab and zinlirvimab. So as we know, these are broadly neutralizing antibodies. They're given as IV infusions. They have 2 different target sites. They've been modified that allow Q6 monthly dosing. Of interest because LEN in combination with these 2 antibodies, they can be packaged as a first Q6 monthly treatment regimen. And there were prior phase 1B and phase 2 trials that were ongoing. Phase 1B was in virologic suppressed adults receiving LEN and TAB and ZAB, with ZAB being offered at different weight-based dosing. And then phase 2 was the investigational treatment arm compared to a group that had continued on baseline oral ART. Week 26 results in the phase B2 results were previously reported at CROI 2025, showing high rates of virological suppression, 96%. And then in the week before IDWeek at EACS, they reported a week 52 viral suppression of 89%. So from this data, we know that it's quite effective in achieving viral suppression or maintaining viral suppression because these are patients already virally suppressed. But the question was, how is it safety? Is it tolerable? So this is what provided data from IDWeek. So they pulled samples from phase 1B and phase 2 and evaluated safety outcomes. And then there was a mention of anti-drug antibodies. So there was 84 patients in this pooled analysis. Median age was 46. High proportion were male, 83%. 55% were white race. And then in regards to safety, injection site reactions, not surprisingly, were more common with LEN. Majority of those were mild, about 85%. And then also not surprisingly, lots of induration nodules, no serious adverse events, and no drug discontinuations from adverse events. And then there was also this mention of anti-drug antibodies developing. So that occurred about 13% for TAB and then 18% for ZAB. They were generally in low titers. It was not felt to sort of impact any virological efficacy. And then there was a separate abstract that focused specifically on these anti-drug antibodies. And they showed mean trough concentrations were maintained above the IC90 cutoff through week 52. And then they also had an analysis that showed there was no impact on PK of TAB and ZAB. So not neutralizing, not affecting mean trough concentrations. not associated with viremia or regimen failure. And so these are just graphical depictions of tab on the left, ZAB on the right. First box in each is day 1 to week 26. Second box is week 26 to week 52, showing mean trough concentrations, and then by the presence of anti-drug antibody status. So there's no difference there, but looking forward to more data on this. So bottom line, in this pooled analysis, safety of LEN, TAB, and ZAB similar to those on oral ART, with exceptions of injection site reactions, and that was from lenacapavir, that remained common. And then so far what we know just from through week 52, anti-drug antibodies are not affecting PK of TAB and ZAB. So this is a first complete twice monthly HIV treatment regimen, still being investigated, promising regimen, still lots of unknowns, logistics of delivery, it's an IV infusion, resource intensive. What are the effects of anti-drug antibodies over time? Because again, this is just 2 doses that we have. And then again, so far it's been studied in virologically suppressed patients. We don't have any data on treatment naive or viremic populations. And so I'm going to skip through this real world, 2 real world studies from LEN, from a multi-center cohort and from the OPERA cohort. But I'm going to, in the interest of time, move on to the next section and focus on 2 drug ARV regimens and start with cabrilpivirine. So to put some background with cabrilpivirine and severe renal impairment, which was the next study, registrational trials of cabrilpivirine excluded patients with a creatinine clearance of less than 50. And then if you take a look at the FDA insert, they just recommend, if you're going to use cabrilpivirine in patients with severe renal impairment, to increase monitoring. Cab and rilpivirine are primarily non-renal eliminated, so it's not felt to have any impact on renal disease. However, there's limited PK data and evidence on the use of cabrilpivirine in people with severe renal impairment. And that includes CDK4 and 5 and those with or without HD. So there was a phase 4 clinical trial that was performed in this patient population. Their specific goals were to evaluate plasma concentration and PK of cab and rilpivirine. And then number 2, evaluate the efficacy and tolerability with our monthly and Q2 monthly dosing. So this was what was known as the CAPRI trial. This was out of Buffalo and a center in Pennsylvania and Pittsburgh. They included 12 participants, adults with CKD4 and 5, GFR less than 30 who were or were not on hemodialysis and were virologically suppressed. For the first 6 months, they got Cabril once monthly, and then past 6 months, they got Cabril every 2 months. And then along these months for 12 months, they did PK sampling of cab and rilpivirine. So again, it was a small study, 6 from Buffalo, 6 from Pittsburgh, median age of 62, about a third were female, 58% were Black, 58% had CKD4, 42% CKD5, and then half of them were on hemodialysis. And these are results of the concentrations of cab on the left, rilpivirine on the right. And you can see very nicely maintained concentration levels of cab, about 8 times the IC90 for cab, and then a little bit lower for rilpivirine, but overall well above the IC90 in general. In terms of virological efficacy, all these patients remain suppressed at less than 50 copies per milliliter at 1 year. And in terms of renal outcomes were stable. Baseline GFR was 15, but increased to 48 at week 48. And that was because 3 of those patients had renal transplantation. So not surprisingly, those renal outcomes improved for them. 1 patient died from an NSTEMI, no significant drug-related adverse events, and then mild injection site reactions were quite common. So the bottom line result for this was that virological efficacy and safety was maintained in people with HIV and advanced CKD, including those on dialysis, and then those 3 who had renal transplantation. And so this adds to a large literature gap on the use of cabrilpivirine in severe renal disease. I think it's really nice to have this data expanding this option to those patients, as some of these patients may be on non-tenofovir regimens, abacavir, have heightened risk for cardiovascular disease. So capivasertib might be a good option for them to switch to and get them off of those other agents. So I'm going to move on to doravirine islatravir with a little bit of background here. Islatravir, also known as MK-8591, has been under active investigation as a part of a unique two-drug regimen, felt to not have many drug interactions, to be tolerable, packaged as DOR islatravir, non-TAF, TAF sparing or INSTI sparing. And then there were prior phase 3 studies that looked at DOR islatravir with a islatravir dose of 0.75 milligrams, found to be non-inferior to other ART, but we did see increases in total lymphocyte and CD4 counts were observed, and that halted production of that dose of greater than equal of 0.75 milligrams. Then after this, there was PK modeling studies that suggested investigation of islatravir daily dose of 0.25 milligrams. And these are current phase 3 trials of DOR islatravir at the reduced dose for HIV treatment. These are studies named 51, 52, 53, and 54. I'll elaborate a little bit on these later on, but studies from 51, 52, 54 were presented at IDWeek, further analysis from this. So this was subgroup analysis of studies 51 and 52, looking at subgroups of female versus male, and then by age and different age groups, less than 50, greater than 50, or greater than 65. Study 51 was a switch study. These are all switch studies in virologically suppressed patients. But the first study here, study design 51, patients were randomized 2-to-1 to receive open label DOR islatravir versus continue on their baseline ART. In the lower study 52, patients were randomized 2-to-1 to receive DOR islatravir or stay on Big TAF FTC. So across both studies, they pooled 708 patients were switched to doravirine islatravir, 356 continued on their baseline ART or Big TAF FTC. They saw similar baseline characteristics between age groups less than 50 and greater than equal to 50, and between male and female groups. And the reason they wanted to study this is to see whether there was any effects of differences in tolerability and viral efficacy, especially in the elderly patient population, which may have more comorbidities, they may be more meds, and see if they're able to tolerate this novel regimen. Efficacy of virologic suppression and safety profiles were similar across all ages and between female and male participants. And so I'm just gonna kind of quickly go over these highlights. So this is from a subgroup analysis by sex and highlighting similar virological suppression results between female, that's 94% versus male, 93%. And as I mentioned, safety adverse events were similar between both groups. Fortunately, we didn't see any adverse events from CD4 counts and lymphocyte counts, and then weight changes remained the same. And this is basically similar results by age. So virological suppression of those less than 50 was 92, greater than 50 was 95, greater than 65 was 96. Again, very similar results for safety in terms of adverse events, CD4 counts, and weight changes. And then this was study 04. So this looked at patients that were in the trial receiving the higher islatravir dose of 0.75, and then were switched to the 0.25 milligram dose. And they followed them through week 48. 639 patients received this dose. At week 48, 94% achieved viral suppression. And then these patients also experienced an increase in total lymphocyte count and CD4 count, which was very reassuring. Bottom line results from these 3 studies. So updated analyses from the DOR islatravir 51, 52, 54 studies continue to demonstrate virologic efficacy and safety in subgroups by age and sex. And then among trial participants on the patients that received the 0.75 milligrams of islatravir. So this is the safe dose. It's gaining traction to support its use as a unique novel 2-drug regimen for the general population. Now we have data and by subgroups, by age, and by sex. And then I'm gonna go through this last study here. This is switching to dolutegravir 3TC with unknown prior genotype. Dolutegravir 3TC is previously studied in treatment-naive populations in Gemini 1 and 2 trials, and then in virologically suppressed patient populations in Tango and Salsa. It's indicated as an initial regimen for treatment-naive patients and as a switch option in those who are suppressed. But there's been limited data on the effectiveness of switching to this regimen in those with unknown genotype. So this was highlights of a systematic review and a meta-analysis. So I'm presenting the systematic review results first. They found 14 publications with over 3,500 patients who switched to this regimen with unknown prior genotype. From virologic suppression and virologic failure outcomes, there was 12 studies, again, close to 3,500 individuals with follow-up ranging from 6 to 33 months. Viral suppression was quite high, 98%, and virological failure was low at 0.29%. And then resistance, there was 9 studies. Only 1 patient found to have an NCRAM detected at virological failure and have some of the follow-up for this particular patient. And then with regards to safety and tolerability, there was 5 studies, very minimal concerns for safety, less than 1 discontinued due to adverse events. And then this was a meta-analysis, so 5 studies that were pooled here. They're reporting viral failure outcomes for 637 patients up to week 48. And the studies are listed there on the left. 0% point estimate of virological failure at week 48 by their common effects model and their random effects model. And then I did include here, but there was also no resistance reported. So these are my high-level summary of the studies I reviewed. And I'm just gonna skip so we have 3 minutes for questions. Thank you so much.
Those were great presentations. One for Vivek, which is Shingrix in our people with HIV and, you know, no longer 50. And so just pushing that right away. And then the second was for you, Jorge, that what you just presented on the dolutegravir 3TC meta-analysis. I think the CID paper on Volver was just presented. And I think there's this push to think about it for M184V, and I wouldn't do it. And I wondered what your opinion was about that, because there seems to be this increasing narrative that it doesn't matter if you had a M184V.
Yeah.
What you just,
I can go first and then.
Yeah.
So
push it in our clinic.
Yeah, I mean, I would agree with that. I didn't investigate the studies they pulled because it would have been nice to know who the patient populations were. I'm assuming they was all people who had not heavily treatment experienced, obviously no resistant mutations that would affect dolutegravir 3TC. But it would be nice to have the patient demographics of who were they using that for.
Yeah. No, I agree. Yeah, with your point. Yes, I totally agree. Yeah.
You know, for those data, we're relying on consensus scores. Like, I was hoping we had a randomized trial, because one can imagine that choose get vaccine or something. That is my only cautious note of caution. It's super exciting. It's plausible, but that's my reaction to that. I was trying to adapt just with the randomized with that vaccine, but there we have.
Yeah, totally agree. Propensity score match methodology has to be done very carefully. It was notable to me, this one seemed to have a really surprisingly high number of propensity score match elements. 63 elements got matched. It's just, that felt like a ton to me in terms of how these are normally done at 8 to 10 or something. And you know, they'll estimate that as pretty good. 63. They were able to do so many and keep it mathematically working because of the giant EHR aggregation. So this might be one of the better ones.
I was actually more equally concerned maybe about deficiencies of ratio.
Sure.
Unmeasured that lead to higher rates of dementia, vascular disease, whatever.
Right.
But yeah, I think both of those are things.
Yeah, I mean,
It's tricky.
the hazard ratio was way too good to be true in 0.6. Makes you think there's unmeasured confounding. Anyway.
I have a question for, I'll just point out, I was very happy to see that VA study looking for COVID vaccination, and they said that everyone had a flu vaccine. So it included people who were willing to be vaccinated, because when you have people who just don't want any vaccine, it may be a different population in terms of health-seeking behaviors. It's a different population, but I hope they will continue to do that. But Vivek, for you with the RSV, so why, I haven't followed the literature super carefully, but why do they go so deep on like, we're one and done? Was that all based on antibodies related to Diane's point of view? Like, why did they, because I feel like I saw second year data that were antibody related where they said, oh, this is great. Like we're going into year 3 and people look good. Is it just that we had no clinical data, or because it sounds like you're saying that the antibodies did go down?
Yeah, I mean, I can't speak to the sort of, there's always this interesting nexus of like messaging and the public health imperative and how we explain these things. The antibodies do seem to be waning. We're just now through the second winter. So sort of like now mid to late 25 is when we're getting a 2-winter analysis.
For clinical.
Yeah.
I thought they already said that the antibodies were good in the second season, which is why they said one and done. Like,
I think the data have been mixed, and I think the preponderance is showing that there's a waning. So,
But Vivek, just to mention the RSV, RSV and pregnancy, there was a lot on that here, and that just how incredible the effects are on babies if the mother gets vaccinated in her 3rd trimester, and only one vaccine, I think, is approved.
Yeah, I didn't include that.
Yeah, but that's it's a huge thing in the pediatric world to start reducing that terrible infection.
It's phenomenal. Yes.
Forgive me if I get this wrong, but I remember, I think it was last year from ID Week that Lisa, I believe, had presented data with a question mark on, I think it was it RSV and flu given together, a vaccination, and maybe attenuating the effect of one of the, forget me, I'm trying to remember the like hint of a finding. Do you know what I'm talking about? Or is this out of?
I don't recall that study from a year ago specifically, but I think there are several that indicate a little. Again, if the patient that we're working with is able to go back a couple weeks later, I always recommend a little space put in.
Did it come up at this conference?
No, that topic didn't come up on this one. You mean co-administration of flu?
Yeah.
No, I didn't see that in the questions here.
Thank you both so much. Phenomenal overview.
And if anyone's online, I'm sorry, I can't get logged in. Sorry.
Sorry, we're going over. Vivek, I had a question. The phage studies are so interesting. Is there a way that we here are able to access phage therapy for, either Staph aureus or any of the gram-negative infections that we see?
Yeah, so the UCSF Health Group is tightly linked with a couple of centers where we can get this done. I think they've treated 6 or 7 people. We have not treated somebody with full bore phage therapy. It's come up into some discussions. And you're right, it's mostly for highly resistant gram-negative infections, not Staph aureus, because we have great options for it. That being said, there are bacteriophages in nature that target a whole variety of bacteria, including Staph aureus. So yes, the way we would get it is, through our group, ID Clinic, and San Diego. There's 3 or 4 centers where you can get in touch. Usually send a clinical referral package. They deem it appropriate. Then you arrange for clinical sample to be sent. Then that'll get screened against a massive library of phages. And then if there's a match, you then start the procedure.
Asking for the breakdown by left and right sided endocarditis.
Yeah, actually, I did not see that, but I'll go back and take a look. It was mentioned that a big selling point was it included left-sided as the overall population, but I think it's a pretty small study. I don't know if they broke it out.
All right, let's wrap it up. Thanks so much to our speakers. Thanks for coming.